And so what will be the strategy for solution? Because the area is very big, right? And for Prof. Kenneth, in terms of economics, how would you advise the government to build more roads, provide helicopters, private service? You cannot be hospital. It's a big area to be hospital. So what is the strategy to deal with rising incident cancer in the rural area?
Yeah, that's a very good question. So we actually tried a few strategies. So one of the strategies is that we tried to bring diagnosis closer to them. So let me share with you, we do have the Magna bus. I think everyone knows about the Magna bus with a mammogram inside. But there was an incident because our road was so bad. So there was an incident where in Belaga, there was a patient that had a lump, but it needs to be diagnosed with mammogram, but she couldn't walk. She couldn't get out of kampong. So we actually brought the bus in, but the road was so bad, by the time the bus went inside, the mammogram was broken already. And that is how bad the situation is. Yeah, so what we did was that our NGO actually were donated with a portable ultrasound. But again, we do not have enough radiologists to come with us all the time to do outreach programs. So that is another challenge. But I think that is a step closer, so we could use a portable ultrasound to have a dual strategy to get a diagnosis faster. So the other solution we were thinking is that we could start a patient navigation service. Of course, this would also incur more costs for manpower and all that. So these are the few solutions that we are looking into. And the third one is definitely the cultural barrier. So cultural barrier is, like I said, very deeply rooted. Okay, you can drag the horse to the well, but you cannot make them to drink it, right? So and that one is a bit tricky. Okay, so there are a few theories. So either that we could talk to the village head or someone they trust in the community. So, but I think this will take we need to be very organized when we want to do this kind of solutions, to implement kind of solutions.
So I guess the solutions have all been suggested by Dr. Lim already. I mean, these are all sort of at the granular or micro level. But I think from the macro side, it's really up to the government whether they have the determination and the budget to remove all these barriers or improve all these barriers or not. So it's both a micro as well as a macro level question. And to target them, you also need to target them at both micro and macro levels.
Hi, I'm Dr. Jana from Cancer Research Malaysia. So I've got two questions. One is for Ishtar, and thank you for your presentation. I'm just wondering, how are you funded? Because you casually said 15 million, and then I'm like, oh my god, how is she doing it? So I'd love to gain some insights on that. And Dr. Melissa, as you probably know, Cancer Research has also gone into the villages in Sarawak. We managed to go into 5 and train people there on breast self-examination, and it was quite a successful program, but we have got no clue about how we're going to expand that. So if you can share some insights on how we can possibly expand programs like this, or when you mention navigation, do you actually mean navigation from the community right up to the hospital? Is that what you meant? Thank you.
So actually we have more in common than you would think, Professor, because I deal in practicalities, as you can see, raising money. We are 100% privately funded, which means, so over the years, the funding has changed. Now we are currently at about 65% funded by recurrent donors, which means small donations, monthly donations mainly. But we are actively investing into increasing that number. And it allows us to understand where we're going to be next year and, clearly control. And then we also, for this big project, so last week I had a very good week. I earned my salary because we got a donation, a commitment to donate 5 million euros for this project. So for big initiatives like this, capital campaigns, you need to tap into major donors. And that is difficult, and it takes a long time, and it can be discouraging and disheartening because sometimes you don't get it. But my answer, and I think we have, the three of us share this, is that money is power. I mean, there is the economics of healthcare, of cancer, do not lie, and you need to be based on real numbers and be practical.
Yes, I heard about the patient navigation system. I think it's one of the kampong that we have been to. It's Kampong Tebakang area, Syrian area. Yeah, so I congratulate you on the very successful project that you did. I think it was with Mahesh, right? Yes. Yes, I'm also very interested in expanding it, especially to the other rural areas of Sarawak. So I'll be happy to speak with you all if you are interested, and we can probably devise a solution on how we can probably start this one.
Any more questions? Yes.
Just to add on to the other question just now on how we can help people to get sick care and all that. One of the studies conducted showed that the cost for travel for Sabah and Sarawak was the highest. And that's the reason why if you see under PKB40, the incentive, Sabah and Sarawak for their travel and transport, you can claim up until 1,000 ringgit, whereas Semenanjung is up to 500 ringgit. But like what Dr. Melissa said, that there is a cultural aspect to that. So even though you're giving patients money to come to do the screening and treatment, patients are not coming. The uptick is less than 10%, 1,000 ringgit, and people are not going. But my question is to Dr. Kenneth. So Dr. Kenneth, it's based on Ms. Ishtar's talk, because you see that the concept of happiness, joy, family is abstract. So how do we, as health economics, to justify investment in intangible measures?
Thank you for that very academic question, Mr. Sayan. I guess the simple answer, direct answer to that is to do quality of health, quality of life assessment. But to get into that area, it takes about 2 days of lecture. So, in simple terms, we collect different populations' perception on the definite or specific element of value, and then give us their preference, or we call it utility. I mean, you know, how much they prefer to that health state, and then we use that data to convert it into what we call quality adjusted life year, and that's how we quantify something from quality to quantity and put it into our models and all these things. I don't want to get into those granular areas.
No, but if I might add to that, is that we work closer together. Meaning that what we do can seem very abstract, and it isn't, because it's rooted in practicality and like everyday conversations with people, but we need to be more data driven, and we need to be better at gathering data, which is hard because sometimes you don't even know exactly how to. We need to be more professional, and if we did, we could share that data and then turn it into studies that would in turn demonstrate that those parents are taking less sick leave, or and then in turn costing less money to the government, or whatever that however you want to portray it. And if you demonstrate that it's cheaper to treat the family in a holistic way, then it will make sense. So we need to work closer together.
Hi everyone, I'm Wilfred from Institute for Health System Research. So my question is to Dr. Melissa. Thank you for sharing this very interesting study. So could you please share with us actually when you conduct the interview, because looking at your participants from various ethnicity, so did you bring along any translator for your interview and also subsequently the translation of your transcript? Thank you.
Yes, definitely. Yeah. So we usually have our nursing team. So usually all these places will have our own KK for the clinic over there. So the nurses over there are usually indigenous people as well, and then they could speak the languages. So the first thing we did was, of course, IBAN language translate to BM. So BM translate to English, and then back forth translation. Yeah. So it's a long process. Yes, I have a lot of transcript. And so Orang Ulu is not too bad. Orang Ulu, they kind of know how to speak Bahasa Sarawak, so we still need to translate that, but it's not too different from Bahasa Malaysia. Yeah, so Iban and then the Bidayuh community is also, of course, in Bidayuh language, and the other one is Melanau. Yeah, so yes, we have to do that, but we usually get local translators to help us with the transcriptions.
Thank you.
Thank you so much for the sharing. Dr. Kenneth, I just want to check, in Malaysia, for crowdfunding models to pull out money for cancer patient eradication, is there any way to make it sustainable in long term?
Unfortunately, I don't sit in the parliament. I don't have any friends there. But I think there is a new approach that is in plan and is about to come out. I'm sure those who work in public institutions would have heard about it. It's called Rakan KKM. My PhD student here is doing his PhD on Rakan KKM, so he would be in a better position to talk about this. But basically, it's theoretically a win-win, an all-win situation whereby patients will have better access to care, and government would be able to solve off some of their financial burden. Instead, they are potentially they can have some income if this plan is successful. And then healthcare workers from public institutions will have better incentive to stay instead of working 2 years in public hospitals and then go to private institutions, which is a brain drain problem. So this new plan is potentially workable, and is something that needs to be given more consideration. The only thing is, as an academic, we tend to be very critical. So in this plan, patients go into teaching hospital, but they also enjoy private patients level of healthcare. So they pay, and then insurance also pay, and also government, of course, provide backup in from behind. But that is a problem, because after all these patients' bed, even in the teaching hospital, they are cost of the government. Government are paying those. So this is only a short-term plan and waiting for the initial outcome of it. But in the long run, I think we still need to sort out the very basic issue, and that is how do we increase the fund? I mean, how do you expand the sources of income for the government? That is the long term. The solution to that will be able to solve the problem. So that's why I propose this. From the long run, we need to develop another source of income, which is from insurance.
Would you be seeing any roles for maybe pharmaceutical company or NGO to be help out in this initiative?
Oh yeah,
as well?
I think a few pharmaceutical companies are already participating in all this patient access program. You know, the names are all here. Rose, Novartis, AstraZeneca, etc., etc. I think they are paying for part of the expenses, but then we all know that the amount of money is huge, and if we were to rely everything on the pharmaceutical company, it's not fair, because they have the business to take care of, and they have their stockholders to be responsible to. So in a way, still need to think of a plan that is more sustainable in the long run, and that is to have a steady income to supplement pharmaceutical company, NGO, and the government.
Thank you so much.
Thank you. Any more? Is there anyone?
Yes, please. It saves me a lot from asking questions. Question for Ms. Ishtar. My name is Ina from RR Child. So you shared a little bit about Parliament Serious Fund and Fundación Aladina. And in Malaysia, I think we do have some foundations that are working to, like Make-A-Wish Foundation, who are trying to bring the angle of the fund into Malaysia. But are you aware of bodies or hospitals or groups in Malaysia or in the Southeast Asian region that is doing some similar work to what you are doing?
I think it's an approach that's getting everywhere. You know, I think it's no longer restricted to whatever happens in the hospital. I mean, I try to make it positive and about fun, but it's hard, no matter the theme. I don't have within the southeastern region. We have collaborated actively with the Philippines with what is it called? Warriors, Cancer Warriors. Carmen, is that it? The name?
Foundation.
Carmen Austin's, I can tell you later. I'm sorry, Cancer Warriors. I'm really bad at names, but not specifically in Malaysia. Not others that I can tell you. But if you are looking for resources, I can put you in contact with the people from St. Jude Global, who work extensively in the region, and they know of all the organizations that are doing similar work and great work at that.
And probably just to follow with Dr. Melissa, cross-culturally, how would we take something like what Aladina is doing? Because we have different religions, different cultures, different languages. How would we in Malaysia try to implement this in a way that's practical, scalable, economically viable?
More complex. Yeah, that's actually a very good question, because you have to take into account so many religions, so many cultures, especially Malaysia, and all such a multi-ethnic group. So you're saying that we want to implement the same thing like this?
If we wanted to make this quality of life holistic, and bringing families, husbands, wives to understand why it's important, adults, children, the whole spectrum.
I think we need multiple sites for this. Yeah, multiple Aladina 1, 2, 3, satellite 1, 2, and subgroup 1, 2, 3. Yeah.
But you start by listening and by doing small things, and then it grows from there. There is really no perfect solution fits all, and each hospital, each region is specific. We work with a lot of people, a lot of immigrants, culturally very different. And the key here is for the medical and the people with the money to understand that it's not, this is a necessity. And once it starts working in a site, then it's easier to extend to others. But it's getting into this it's like it's like a torture, you know, like drop by drop by drop, and then in the end, everybody has understood that this is the standard. So you just start.
But I guess like everything, it comes with a cost. Like for Sarawak, our Children Cancer Society is also very strong. So when it comes to like children especially, you know, that is like everyone will come together. Like it takes a village to raise a kid. So, and it takes a village to treat a kid, to cure a kid. You know, so everyone will just come together. Yeah, so I guess that, like she said, you start small and then people will just come. You know, you fight for your cause and the people that have the same cause will just follow you. Yeah. Yes.
Maybe last question?
Yeah. Last question from one person, I can give a few questions. All right, I'm Yusuf from Taylor's University, but I'm attached to, or affiliate to medical NGOs that doing almost similar, a lot of similar projects like Dr. Melissa. So I understand the difficulties on going to the rural areas, and we have one project doing dental screening and dental care for the Sarawak. Maybe I'll take to you later, we can do something. Now, first question for Ms. Ishtar. This from the beginning. My wife is from legal background, so legal and medicine is not in the same, usually in the same, environment. Usually we fight in court, so not in my house anyway. So what is your motivation first from legal background suddenly into this field? That's not yet. No, because once I sit, then I cannot get the mic. The next question would be, I'm not sure whether there is a data on this. This would be, I think, for Dr. Melissa and Prof. Kenneth. I'm sure in terms of the value, money values, I'm sure we are spending more on treatment for cancer, But when we talk about the whole care, I'm sure we are supposed to be doing more on early detection, screening, awareness. Because at the end of the day, if you look at the economic impact to either the countries, because we are highly subsidized on medicine, treatment, etc., and also for the families and patients, I think we are supposed to be going towards more preventive and early detection, because the economic impact or burden will be much, much less. We are starting, for example, a project for the refugees in undocumented, talking about cancer, and we opt to go for a screening outreach program rather than paying for the treatment. Because I think we're supposed to be going that way. What is your views on this? On fighting more towards screening, spending more on screening, and or advocate more on screening and early detection rather than spending more and more on treatment and advancement in treatment? Yeah, that will be for all of you guys.
Probably I can add to that question because I also have.
Okay, I'm going to be very quick. Just to say, you need a multidisciplinary team in everything that what I am proposing, I think what Dr. Melissa is proposing, Dr. Kenneth, Professor Kenneth, sorry. And I got here by chance, but what I do is I solve problems. I think I go to the source, I figure out what's lacking, and then I bring the solution. So how do I structure this? How do I carry out this project? How do I get the money? And you don't need to be a doctor in order to do that. So I think it's actually positive that I'm not a doctor, because I see things differently. And so I think everybody is welcome in this space. In terms of what I do, I don't see it as medical. I see it as improving quality of life for me. It's children with cancer and families. So anybody's welcome. I mean, nowadays I think I should have gone to med school because I would understand more when I attend these congresses. I'm fairly limited, but
okay, I'll be very quick and I'll pass to Prof. Kenneth. answer the rest. Yeah. I guess it all dawns to political will in the end. Yeah, like what? No, you're not gonna pass it to me. You're gonna talk. Yeah, political will in the end. Okay, so because I think in Malaysia we do a lot of opportunistic screening, so we expect people to come to us. We don't reach out to them. I did my PhD in Okayama for 4 years in Japan. Even as a resident there, I got a screening program. They were saying that you are above age 35. Okay, now you know my age already. They were saying you're above 35. You're supposed to do this. I was shocked when I got that in my mailbox. That a foreigner like me, they also reach out to do screening, like all kinds of breast screening, cervical cancer screening. That is the thing that we don't get in our country, which I think is very important, because when you get that, then you know that the government is doing something. They're trying to reach out. Yeah, so I think, at the end of the day, it's political will. Yeah.
You answer the money part.
Yeah, probably I want to add to that. I'm sorry, we have some more time. Because cancer financing is something that was discussed. Yesterday, the whole day, they were discussing about cancer financing. And we always talk about treatment accessibility, but this is from your point of view, and how do we actually prioritize and highlight this, especially in the national control plan for cancer, so that the financing also goes towards prevention and screening, early detection, meaning the investment should be going towards that as well. It is very much also important as much as accessibility to treatment.
I guess everything is pretty much said already. As I mentioned in my presentation, prevention is always more effective and more cost effective than treatment. We all know that how expensive it is once the patient is admitted to a hospital. And even if the patient survives, the rehabilitation is also expensive. So whether it be secondary or tertiary care, they are all more expensive and cost more money than doing preventive care. So we all know that. I think the politicians also know that. But there are tremendous amount of resistance to how to shuffle more money from secondary and tertiary level to primary, because we all know that the hospital people will be very defensive if you take away budget, right? There's a very bad battle that you have to fight. But then apart from that, I think Dr. Lim has also mentioned one very important thing. Despite the willingness and perhaps the availability of funding to do preventive medicine, say for example do screening, I think the population in general will need to be receptive to that. I think it really boils down to a cultural level. I mean, you have the money, you have the setup, but nobody comes.
I think if we do the same study that you do for the Sarawak in, for example, in Selangor, almost the same points will be.
You get the same kind of pressure as well.
Taboo and all that. For example, peer pressure. Nobody say about peer pressure, but if you go to one mosque to do, if we open up our clinic, say come and do breast screening, rarely people come. But if you go to their mosque, for example, one person will talk, hey, let's go, join. They will come as a group. All the pensioners, Kwing-Chin, they will come as a group, and they're willing to come because they in the group, they come to our place, so they open up more opportunity for screening. So I think you go for rural, you go to urban area, the mindset
it sounds like it's a basic health literacy that we are tackling.
And also, if I might add, from a very practical perspective, sometimes these results take time, and politicians are not necessarily in the game of long term. They want they want sometimes immediate results. So if you're talking about literacy or screening programs that are going to yield results in many years. And this happens everywhere in different aspects. And it's something we are all trying to fight with.
Okay, so I think that ends the discussion today. Thank you very much to everyone and to all the panelists for the discussion.